Health One Technologies. Thank you for attending our webinar this afternoon. We are going to be discussing how to prepare for meaningful use attestation for 2013. And we're also going to get into the preliminary discussions on how to get ready for Stage 2 in 2014. Presenting with me is Tanya Martin, who is the COO of Health One Technologies. For those of you that are not familiar with Health One, we are a consulting firm specializing in the implementation and maintenance of GE centricity. We do everything from building forms, writing reports, training, meaningful use, anything that goes along with the product. A few things I just want to talk about briefly before we get started is that we are going to have an opportunity for people to ask questions at the end of the session. Everybody should have a questions window in their GoToWebinar, so if you have a question, certainly feel free to type it in there. We do ask that you hold the questions until the end of the webinar. Today, one more thing, the actual video of this webinar will be published up after it's completed, so if anybody wants to watch it back, you will be able to do that. We will send that out once we get everything organized after this session. So today we're going to talk about a recap, basically, of what meaningful use is. So just a quick review of the stages, some dates to remember, the payment schedules. And we're also going to briefly talk about audits. For those of you that may have been audited or are anticipating an audit, we'll just do a quick review of what that looks like. Tanya is then going to discuss attestation preparation, just the things that we need to make sure happen before the end of 2013 so that we can complete our attestation fully. And then we're going to get into discussing Stage 2, including the details of some of the core measures, actually all of the core measures, a quick review of some of the technical areas that we're going to need to focus on for Stage 2, including upgrades and some additional software requirements. So at this point, I'm going to hand this over to Tanya, who's going to just review the beginning stages for us and the preparation for attestation. So Tanya, you want to go ahead and take it?
Yep, thank you. Good afternoon, everybody. This slide that we have in front is the stage methodology. I'm sure everybody has seen this. The one piece that you may not have seen recently is that in 2014, we need to upgrade to certified code. So what that means is when we started meaningful use back in 2011, ONC had actually put out the 2011 edition of the EHR certification criteria to support meaningful use. And they have done such in 2014 as well. So we need to make sure that the software is on the 2014 certified code. One of the things that I do want to point out on this slide is that in 2014, whether you're a Stage 2 or a Stage 1 provider, you will all be doing a 90-day attestation, and it's based off of 1 calendar quarter. So when you do your attestation in 2014, we won't be moving around throughout the year and saying I'm going to attest in October or I'm going to attest in September. It's all based on a calendar quarter, and everybody, regardless of stage, attests for 90 days. You hit that next slide, Jen. Some of the dates that we need to remember, October 3rd of 2013, that's the last day, well, it was the last day to start your attestation period for Stage 1 for this year. December 31st is the end of the reporting period for Stage 1, and February 28th, 2014 is the very last day that you can attest for 2013 Stage 1. Once you do your attestation, you can now start to prepare for Stage 2. I'm sure that everybody has seen this slide a million times, the incentive payment schedule. The incentive payment is 75% of your Medicare allowables, and there is an annual cap. One of the things I do want to point out on this slide that in 2013, if this is your first year doing attestation, your incentive payment drops to $39,000 as opposed to in previous years, 2011, 2012, where you was getting the full $44,000. In 2014, if that's going to be your first year, you will drop to 24. You can hit that next slide, Jen. Stage 1 attestation preparation. So we're almost there. We're almost done. Couple of things that we do need to remember. Syndromic and immunization tests. We'll talk about that in a little bit more detail in the next slide. Your security risk analysis. Looking at those reports and monitoring them throughout the year. At this point, it should be based off of how well you've been doing this year if you're testing for a full year. And then gathering all of the attestation documentation. So for syndromic and immunization tests, the first thing you want to note is that you should contact your state agency as early as possible to make sure that the testing can occur with your state. Or if your state is one that is filing exclusion, you could also contact them for that. In the next slide, we'll actually take a look at a sample state and what that state has to offer in terms of applying for an exclusion. So many of the state registry websites offer these letters that would be printed offline for differences in the HL7 version. So the state may have one version and GE may have another version, and the same with Syndromic. To my knowledge, most of the states are just not ready for Syndromic yet. There are a few that do have that available, but the submission for Syndromic for most states is not available. When you actually get to the point with the state that you can test, you need to make sure that the testing is complete. Any of the technical components that need to be filed or put in place for submission are available, and then you need to actually do the test. And whether that test is a failed test or a passed test, you need to make sure that you have the documentation for that testing. So this is an example of what Florida State's website looks like for Syndromic. So if you go on the healthit.gov website, you'll actually look at Florida State, and they actually will provide this documentation as proof that they are not ready to accept syndromic surveillance data. You'd fill this in, whether you're a provider, an eligible hospital, and eligible professional, and what objective that you're going after, whether it's syndromic or immunizations, and then a default letter will be available to you that you could actually keep for your audit files. Each state is different. Some states don't have this. Some states actually just have it on their website. It's just a note on their website, and you can actually just print that note down from the website and go from there. The second is the immunization registry reporting. So the ccd.gov website is actually a really good website for this. The map will come up once you click on the reference information off to the right of the screen. And you could click on the state that you live in, and a box will open up, and it will actually give you your state's website, your state's immunization registry website, and it will give you the contact information. Any technical contact will be listed if available, and any communication contact will be listed if available. So here's where the fun begins, the security risk analysis. So I think in previous years, everyone kind of glossed this over. It is something that in coming years is a little bit more focused, but in stage one, what we need to look for is a performance of the risk analysis. So there's a grid that's floating out there on the web that you could actually use. You need to make sure that the risk assessment, whether you're in year one doing your attestation or year two, year three doing your attestation, that you do the risk assessment. So the first time you actually do the risk assessment, you would fill out the grid. You make sure that you have your documented procedures. If there were any deficiencies along the way, those were documented. They need to be documented, and an implementation plan along with dates to correct the deficiencies need to be documented. If you're in your second or third year of attestation, you actually need to review that assessment, the original assessment, and do the same process. So you need to make sure that your procedures are up to date, and if there were deficiencies throughout the reporting period for those following years, that those actually have documented implementation plans with dates for correcting the deficiencies as well. We actually like to use global data systems to do the risk assessments for our clients. They are highly skilled in security risk assessments and creating policies to support the providers and the provider practices with this. It is highly important in the coming year that this actually assessment gets done and it gets done correctly. One of the pieces that we actually need to hone in on is looking at the reports for your attestation. So if you're in your initial 90 days, verify that the provider registration is complete. So go onto that CMS website and make sure that you're not stuck in a non-completed status for your registration. Once you do the registration, don't let it just hang out there. You need to actually go back into the CMS website and just verify that you're complete. You need to monitor the reports for full compliance. Throughout the whole year, this really should have been done. At this point, if you have deficiencies with your data, then you actually need to go back in and monitor those reports more closely and more timely. So at this point, you should be running them every week, every 2 weeks, if you find deficiencies within your report. Some of the things that you may need to address are workflows or compliance issues. One of the other things that we continue to tell our clients is that you need to complete all of the yes and no measures and make sure that they're documented. So things like verifying the clinical decision rule, make sure it's in place. Gather all of your security materials, that's including your policies and your procedures. Run your patient list if you're using that menu measure. And lastly, make sure that your CQM reports are run. In order to prepare for your audit, make sure that you have an electronic copy or a hard copy of all of your documentation, and that includes your yes-no measures. So in preparation of an audit, a couple of things to note. So you typically have 14 days to respond, and that's for a prepayment or a post-payment audit. Things that you'll need in your possession is the proof of your EHR certification. So make sure that you have your EHR vendor certification handy. You need proof of all of your core attestations, including those yes and no objectives. You need proof of your menu measure attestations, including the yes and no objectives, and your security risk assessment, including those policies and procedures. So that actually would all go to the auditor. At this point, I'm going to turn the presentation over to Jen Monahan.
Thank you, Tanya. So now what we're going to do, now that we are hopefully ready to attest for our last year of stage 1. Some of you actually may be doing stage 1 again next year, but for those of you that are moving on to stage 2, we're going to talk about the boatload of work that needs to happen between now and our attestation period for stage 2. I do apologize. I think there's a slight delay in our slides, so I will do my best to try to keep up with that. The next slide that I'm showing everybody is just a sort of reference slide for you in case you're wondering if you want to read what the final rule is for stage 2 or if there are certain pieces that you need to pick out of there. So this particular slide is just in here as a reference for folks if you need to get information on various information within stage 2. So what I'm going to talk about today with stage 2 planning is basically what the implementation process is going to look like and the reporting timelines, changes to the measures, and I'm going to focus on core measures only today. I will do a review quickly of the menu items and the CQMs as well, but my main focus is going to be on the core measures. We're also going to talk about the upgrades and also additional software requirements because this is going to be a key area that I see can cause some delays in our stage 2 implementation. So first off, let's talk about the timeline. I think Tanya mentioned earlier that in 2014, regardless of our stage, whether or not we're stage 1 or stage 2, we're going to do a 90-day calendar reporting period. So this is going to be important as you're planning what you need to do for stage 2 for things like when do I upgrade? When am I going to implement a patient portal, for instance? When do I adjust my workflows? And all of those are important because we're going to have clear timelines established to make sure that we can meet the reporting, the attestation period within the quarter. So for instance, let's say that maybe GE releases CPS 12 or 9/8 in December, January timeframe. Let's assume that we can upgrade in Q1, maybe Q2 of next year. That will mean then that we need to make sure that all the other components are in place so that we can begin our attestation either in Q3 or obviously no later than Q4. So there's going to be some critical aspects to planning for stage 2 because if something gets pushed, if the upgrade doesn't happen until Q2 or Q3, then you're going to be really pushed to make the attestation for next year. General overview of the changes. So in stage 1, we had 15 core measures we had to select, and we had 5 menu items that we had to pick. So in stage 2, we now have 17 core measures that we have to meet in order to be compliant with the attestation. And we also have 3 menu items that we have to select. So all of those have to be done as a total of 20 objectives. They have to be completed in order for us to be compliant with the meaningful use. There are other things that they did. So within a measure, they've actually put 2 measures. So we have to meet both of those measures to successfully achieve that goal, and we'll review a couple of those today. And then the other thing is with our menu items, we can no longer pick an exclusion for something if we can meet another measure. So it's not that we can't exclude from something, but if there is a measure that we can meet, we have to select that and we can't do the exclusion. So all of that is going to make it a very challenging process to get to stage 2. The next slide that I have just quickly lists out as a reminder for us what stage 1 core measures were and also a quick list of what the stage 2 core measures were. I will say for me personally, my biggest pet peeve is that they changed the numbers on us. So I always knew that CPOE was number 1 and in stage 2 it might be something different. So that was one thing for me. I think everybody started to memorize the meaningful use numbers and now we actually have to relearn that a little bit. But we're going to get into reviewing all of the stage 2 measures and the details behind it. And again, if you have questions, just hold them to the end, and we will get through them once we get into the webinar. So first, core number one is CPOE. Most of you are familiar with this from last year. So it was, again, the computerized order entry of medications last year. So now what they've done with CPOE is it's not only medications, but we also have to enter lab and radiology orders into the system. This is going to mean that for those of you that have not implemented the orders module in Centricity, you're definitely going to need to do that. And this is one of those areas that you could start focusing on now. Even while we're waiting for the upgrade, we could certainly implement that our practices are doing lab orders and radiology orders. The other thing they did is increase it from the medications from 30% to 60%. And I know for many of our practices, this was an area that providers struggled with. So that 60% compliance is going to be something that we're going to have to monitor closely to make sure that everything's getting into the system in a timely fashion and by the right person in the office. Core number two is ERX. And that one is going to allow, it basically is the same exact measure. All they did is bump this up to 50%. So last year it was 40%, this year it's 50%. And they also combined with this one the drug formulary. So the drug formulary was a separate measure previously. That one is now listed with ERX. But if you're e-prescribing, more than likely your formulary is already available for you. Core number three is recording of demographics. So this one they changed from 50% to 80%. This is one that I feel like most of our practices that we worked with did not have much of an issue last year. Many of our folks use a meaningful use checklist form, which I have on this screen, and it will tell the providers or the staff if something is missing from their demographics, or as we get down further, you'll see vitals in other areas. So we have found that the implementation of this checklist form has substantially increased compliance for our providers. Core number four are vital signs. So this one has changed a little bit as far as what we can exclude from and what the measure actually is. But the important thing is that this actually also went to an 80% measure. So again, it was 50%, went to 80%. The few things that it changed, and actually I think it's a positive thing, it allows us to exempt from blood pressure, for instance, and only attest to height and weight, or we can exempt from height and weight and only attest to blood pressure. So those changes actually went into effect for stage 1 in 2013. They just continue over for stage 2 in 2014. Smoking status, again, this went from a 50% to an 80%. Same exact measure, patients over 13. And again, I have a little print there of our checklist form so that you can see if you capture smoking status, it will help your providers make sure things are where they need to be. Core number 6, clinical decision support. So this one I think is going to be a little challenging for some folks. So in stage 1, we needed to do one role, one clinical decision support role. And they've actually upped that to 5 roles for this year for stage 2. And 4 of those have to be directly related to the clinical quality measures. So I think that's going to be a challenging thing. I actually envision what they're doing is that potentially in the next stage of meaningful use that they're going to start to look for some improvement in our quality reporting options. So I'm thinking that they're really focused in on trying to make sure providers are guided in the right direction for improving quality. This is going to be an area that I think will be challenging for many practices to implement and deciding how they get it implemented into their workflow. whether that happens with a form that the provider is using, or maybe some third-party application that's tagged in Centricity. It's an area that people tend to sort of not focus on because it's a yes-no sort of measure. But I think it is going to have some long-term effects that we're going to need to really spend a little more time on this year. The other thing they did with this particular measure is they rolled in the drug, and drug allergy interaction checks. So that is all rolled into this clinical decision support role. Core number 7 is the patient electronic access. So this is our patient portal. We need to have over 50% of our patients that have the ability to have the portal, so that means we had to have generated access for them. I think the more difficult thing for anybody to do is the second part of this measure, which is 5% of those unique patients that we've given access to the portal, we actually have to make sure they have done something with the portal. So I think that's going to be a very, very challenging thing. We're going to have to encourage patients to get more engaged by using their patient portal to actually do something, download something, view their information, something along those lines. For those of you who have not implemented patient portal yet, this is something that I would suggest we get started with sooner rather than later. It's definitely not a slam dunk implementation. It takes a little bit of time, especially considering that we have to make sure our patients are using it. So we want to just focus in on that. Clinical visit summaries, which is core number 8. This measure is the same for percentage, so it's still 50%. What they changed here is that in stage 1, it was within 3 business days, I believe, and in stage 2, it's within 1 business day. So basically, when the provider sees that patient, they need to provide the clinical visit summary right away. Some of the things that I put here to note is that we may want to consider distributing the summary via our portal, just to kind of make that one day a little more accessible. Or also, if you have not already, making sure that the checkout person or whoever is in checkout in the office is printing that summary at that point in time. Core number 9 is protect health information. So this is our security risk assessment. It's pretty same process in that we still need to do the assessment, write our policies, any deficiencies that might come up, and also they're stressing encryption and security of data at rest in this measure. Again, I would highly recommend that if you have not done so already, that you engage with a third party that specializes in security risk assessment. It's definitely something that our clients that have gone through the process find very beneficial. So if you haven't done that, I would encourage you to do it. Core 10 is lab as structured data. So this one was a menu item in stage 1, and in stage 2, it's now a core item. More than 55% of lab tests that the provider ordered actually need to be incorporated into the EHR in structured data format. So if you do not have a lab interface currently set up in your system, then this is something that you're going to want to look at soon. And if you do have a lab interface, you also want to spend some time perhaps just verifying that your cross-reference files are actually working correctly and that things are being updated as they should be. Core 11 is generate a list of patients by condition. So this is that just running the patient list in Centricity. Pretty straightforward. It was a menu item in stage 1. It's now a core item in stage 2. Core 12, patient reminders. This was a menu item as well in stage 1, and it's now a core in stage 2. They also did something in this one. They decreased it from 20% to 10%. So there's actually a decrease in this measure. And they've also changed the age ranges a little bit. In stage 1, I think this was when ages 5 and under, 65 and over. It's actually for all age ranges now. And they added a criteria if they've been seen twice in the past 2 years. But again, it is a core measure. So we're going to have to make sure that in some way, shape, or form that preventive follow-up care reminders are getting out to at least 10% of our patients. Patient education is, again, a menu item that was moved to a core item. It's still 10%, the same as it was in previous years. The one thing that I think is going to change with this from GE's perspective is I believe they are going to encourage the use of some third-party education resources from within the system. I've sort of seen those in various webinars and discussions with folks. So I'm hoping that we get to do more than just the medication handout that we have right now available for us as patient education in Centricity. Core 14 is med reconciliation. So this is one, again, was a menu item. Now it's a core item. It's still 50%. The measure is exactly the same. But everybody has to do this one now. We don't have an option. This is one where if you are currently using some sort of meaningful use checklist form, or if you have a workflow in place where med rec is happening, in most of our practices and situations, we actually see most practices are doing this on a regular basis. They might just not be documenting it the correct way. So this is an area that you could potentially begin to implement well before your upgrade and everything else that needs to happen in 2014. Core 15 is a little bit of a mess. So this is a transition of care. Again, this was a menu item in stage 1. They've moved it to a core in stage 2, and they've also increased how we are communicating with other providers. So with this one, you are definitely going to need some sort of option to securely communicate to other providers. There are a couple of vendors out there, Qvera, and I think GE is also offering a solution that will allow you to communicate with other providers on different EHRs as well, so it doesn't have to be obviously Centricity to Centricity. What they're doing with this measure is they're saying if a provider transfers the patient to any care setting, so whether that's another specialist, a hospital, nursing home, anything like that, for more than 50% of those, we need to do this summary, this patient summary that gets sent out to the other organizations. And the other part of that, which is the second and third bullets here, is that it's telling us that we need to do this electronically. So 10% of those actually have to be sent electronically and not on paper. So this is going to be a measure I think is going to impact most of our physicians in a way that is going to require them to do more when they're transitioning those patients. And I think there's also some opportunity to sort of really define what transition of care is. So this measure is one that I would suggest as organizations spend some time looking at and just really kind of understanding, because it's definitely going to impact the practice. Core 16, immunization registries. So this one was a menu in stage 1, is now a core. So if you give immunizations in your practice, you are now going to be required to complete your immunization registry, assuming that the states are compliant and all of that. And I think since this has moved to a core measure, we're going to see that most vendors and states are going to have the ability to do this. Again, this is something where we may need to use Qvera. For those of you that aren't familiar with Qvera, it's a product that offers an interface engine and would allow us to send these immunizations to state registries and modify them as needed. And there's also Centricity's Clinical Gateway, which is built into the product that you can use as well. But we are going to, if you do not have a state immunization registry currently in 2014, that's something that you're going to have to put on your radar to do. Core 17 is secure messaging. So this is requiring us to be able to communicate with our patients, and we want to make sure in this measure it's actually telling us that 5% of those patients need to communicate with us. So it's going to be, again, one of those that we need to be able to encourage our patients to use the technology that we're implementing in the office. Okay, so that is the detail, most of the details of the core measures for stage 2. There are a few measures that are combined together. So as we discussed, the first bullet here, the drug-to-drug, drug-to-allergy check has been moved in with the clinical decision support rule. The maintain, the problems, the meds, the allergies, that is all put into that transition of care. So that all rolls into that one particular measure. We don't have to do those as separate measures anymore. In stage 1, prior to 2013, there was actually an option that says, are you reporting your clinical quality measures? And it was just a yes-no measure. That actually goes away. We still have to do our submission for clinical quality measures. It's just that standalone measure will go away. And in 2013, we can still manually submit, which means we can plug into the attestation, our numbers for clinical quality. But in 2014, that is going to have to be an electronic submission. So we have to be able to submit electronically beginning in 2014. And then the drug formulary checks, that got combined with e-prescribing. They removed 2 measures. They removed the capability to exchange key clinical information. That was actually removed for 2013 forward. And then they also removed the provide the 10% of the patient's timely access, and that one is actually now rolled into your patient portal. Just real quickly, because Tanya and I are envisioning having future webinars where we're going to discuss the menu and the clinical quality measures. This is a quick slide to kind of tell you there are now 6 menu items that we can select from in stage 2. We have to select 3 of those to be compliant. So our options are kind of limited here, and I think that is going to be something that we need to pay attention to. Clinical quality measures, again, we will talk in more detail in future webinars, but we basically have to pick from certain domains. They have to be submitted electronically. And if we do have large groups within organizations, they can actually do this, whether it's part of GPRO, I don't know, probably my larger groups are familiar with that, or if you're in an ACO, there's some opportunities. So we will discuss these in more detail in future webinars, but for today we just kind of wanted to let you guys know that there are changes to it. Okay, technical requirements. This is an area that I think is going to be most hurtful or challenging to everybody on the call, and that is, first of all, we have to upgrade. So we have to upgrade to the 2014 certified product, so whether that is CPS 12 or EMR 9.8, depending on what your organization is currently on. Rumor has it that we will probably not see either of these products for general availability until January, perhaps late December, but I think it's probably going to be January. And then as an organization, you're going to have to make that decision. Are we the first people to implement, or do we wait a little while? That's going to probably be impacted by other things that you have to do to meet stage 2 requirements. And then as we went through the webinar today, as I went through the core measures, I sort of talked about, okay, core 7, patient electronic access means we have to have a patient portal. So if you don't have that, we're going to need to get it, install it, make it efficient, make sure it's working. Core 15 is the transition of care measure. So that's the one where we need to have some kind of integrated secure messaging, and whether that's a GE product or Qvera, using one of those, we're going to have to make sure that's in place. Our immunization registries are going to require, again, either GE's built-in gateway or a Qvera product. Secure messaging, core 17, we need to have a tool in place for that. And then for the clinical quality measures, some of you may have seen this or may not have seen this, but there is going to be a new reporting tool available in CPS 12 and 9.8, which is sort of like a cloud-based reporting option that will be available within GE. So we're going to need to have that in place to submit our quality measures for stage 2. Okay, that was a whole lot of information. We encourage you all to start as early as possible to begin planning for stage 2, and that may mean looking at some of the workflows that we can right now to see if we can adjust things now in preparation for stage 2. Also getting planned when you want to actually do your attestation so that you can try to backtrack and say, okay, we need to upgrade by this day, we need to have our hardware or our third-party add-ons in place by this date, and then we need to have our training and workflow and all of that in place as well. So there's definitely a lot of work to do in 2014. I think it's just at this point in time getting ready to plan for that as much as possible. Tanya and I will be hosting another webinar in December of this year. Our goal at that point is to perhaps focus on stage 2 menu items and clinical quality measures. If we are lucky, I put here ... with smiley faces. We'll have CPS 12 ready to review, or 9.8, one or the other. So I'm hoping that we will have a glimpse of that in December for our next webinar. If not, we will just continue focusing on how we can best plan for stage 2, given what we have available to us right now today. Okay, so that concludes the information that I have available. Do we have any questions in the forum?
Jen, we actually do. This is Tanya. So one actually is just a piece of information. So New York State, they do have available uploads for Syndromic and Immunization through their, I think it's HIXNY, H-I-X-N-Y, their RIO, in the format that the state prefers. So if you need information about that, you guys can message us and we will get in contact with the person who has sent that information on to us. Our next question is, why do you suggest GE will release CPS 12 in Q4 2013? We are under the impression GE pushed the release date to Q1 2014. It will be challenging at best to attest in Q2 or even Q3. This delay will force most of us to have the opportunity to attest in Q4 of 2014.
Yes, and I think I did mention that originally GE was hoping to release that product in Q4 of 2013. I have heard that it will not be available until Q1, January, hoping early. Assuming that it's available for release, we could still have people that would be able to upgrade in Q1 if we have everything in place and ready to go. If not, you're correct, it will be Q2 before we can put anything in an upgrade in place and functioning, working in the practice. I think it will be challenging to meet stage 2 for almost everybody next year. I think it can be done. There will definitely be a lot of work in Q2 and Q3 of next year if we plan on testing in Q4.
Thanks, Jen. We've got quite a few questions here, so I'm just going to read them through.
Okay.
For Core 12, do you have any recommendations for orthopedic preventative patient reminders?
Talk about getting put on the spot with that one, huh? You had to pick ortho? You know, I think there are maybe some medication ones that you could put into place, or maybe certain osteoporosis diagnosis, things like that, that you may be able to put into place. I would go back and look at your guidelines, you know, whatever the academy guidelines are for clinical measures for that particular specialty, and, you know, see if there's something that's there that you can, you know, put back to your practice and make it actually useful for what you do. But I think that's something that you would need to work individually with your practice and your providers and get a feel for what would make sense to them.
The next question is, any insight on how GE plans to use the EMR system to suggest handouts based on a patient's clinical condition? It does not do that in version 9.5 or 10.
Yeah, I saw a presentation. I don't know how formal this is, so certainly don't hold me to this, but I did see something that was referencing a third-party product that they were looking at. Kind of like, you know, they used to have the handouts, the exit care handouts that were in the system. And I'm not sure if they're going to be doing this with their new HTML forms, or if they're going to give you some option in the system. But I'm thinking that they're going to pass information from the problem list to this third party and somehow allow it to interact. I know we have done something similar with mail programming on forms before, where we had a program we were working with that allowed us to do clinical decision support. And we were able to take information from a form and pass it to that third party and then get the decision support back. So I'm assuming that that's kind of what they're looking for, is that they're trying to maybe look for a third-party solution without it being built into the system. Again, that's just kind of what I had seen in passing in a webinar. I'm not confident that that's what they're going to do, but that's what I kind of think they're leaning towards.
Thanks, Jen. We cannot query the immunization registry or pull data into the EMR. Any suggestions?
I think I need further clarification on that, but we're looking to maybe load immunization information in the EHR. Is that kind of the tone you're getting from that question, Tanya?
Yes.
So I believe maybe that the Qvera product might offer a solution for that. There is another third-party product out there that allows you to take information from registries and such and potentially script it back up into Centricity. So if that's sort of where that question is going, if you want to reach out to me after the webinar, I can certainly pinpoint that in a little more detail for you.
The next question is, if you select a measure, can you still record a 0 if none applies? And this is in regards to CQMs. So the answer to this question is yes, you still can record a 0. The next question is, are we still able to report an exemption for syndromic and immunization if we are specialists and these are not applicable to our practice for both stage 1 and stage 2?
So for immunizations, the answer is yes, you'll be able to do that. If you don't give any immunizations, and that means if you're not giving a flu vax or anything like that in the practice, then yes, you would be able to exclude from the immunization registry. In stage 2, for our menu items, we still have syndromic surveillance and a few other areas that we can choose from. But if you're able to, for instance, meet 3 of the things, and orthopedics is a good example, like if on the menu items I could meet that I can do electronic notes, I can do imaging, I can do family history, then I cannot exclude from syndromic because I can meet those other measures. So I think that we will have more discussion about what the menu items look like on our next webinar. And I think that would be a good opportunity for us to really focus in and say, yes, you can exclude from syndromic or not. But as immunizations, yes, you will be able to exclude if you do not give them.
Next question is currently 9.8 is, I'm sorry, it's not a question. Currently 9.8 is targeted for Q1 2014, February through March time.